Adoptive T-cell therapy, or CAR-T therapy, involves removing one's T-cells and genetically engineering them to identify a certain tumor-associated antigen, and then reinfusing these revved-up T-cells into the patient to storm through the body, looking for and destroying tumor cells expressing the antigen the cells were trained to recognize. While it is certainly a significant breakthrough in the treatment of cancer, specifically hematologic cancers, it is not without risk. Cytokine release syndrome, or cytokine storm, is highly associated with CAR-T therapy. Cytokine release syndrome comes as a result from severe inflammation and active cytokines within the body. In the days to weeks after infusion of one's T-cells, nurses should expect to see some degree of cytokine release syndrome. There may be a link between disease burden at the time of therapy and the degree to which cytokine release syndrome presents itself, and may also be an indicator that engineered T-cells are activated and fighting cancer within the body. Mild cytokine release syndrome may present with flu-like symptoms. However, more severe cases may correlate with high fevers, which can often exceed 105 degrees Fahrenheit, along with hypotension and lab abnormalities. While cytokine release syndrome in the acute phases after CAR-T therapy is expected and highly likely, sepsis might also be a possibility and should at least be considered until it can be ruled out. Patients often require immediate hospitalization upon suspicion of cytokine release syndrome to initiate supportive care. In addition to vigilant monitoring of vital signs, laboratory values, including chemistry panels and ferritin levels, should be monitored. Chemistry panels may lend information about the degree of organ toxicity, and an elevated ferritin has been linked to more severe cases and indicates the level of stress the body is enduring. Other signs and symptoms seen with cytokine release syndrome may include vascular leak, hypotension, pulmonary edema, hepatosplenomegaly, and liver dysfunction. Critical care may be needed as patients may require vasopressor therapy, mechanical ventilation, continuous renal replacement therapy, or simply a lower nurse-to-patient ratio than can be afforded on medical oncology units. In addition to supportive care, some pharmacologic options are available for the management of cytokine release syndrome. Tocilizumab is an option for severe cases. It is an immunosuppressive monoclonal antibody that inhibits IL-6. While tocilizumab has shown effectiveness in reversing cytokine release syndrome, it may or may not reverse the effect of the engineered T-cells. We still need research to know for sure. Corticosteroids may also be used to subdue the immune system, but also may very well render the engineered T-cells ineffective. Therefore, the decision to administer tocilizumab or steroids should not be made lightly. Although there are limited case reports of patients treated with CAR-T therapy, there have been documented cases of complete responses despite severe cytokine release syndrome that required immunosuppressants. There have been cases of complete responses with little to no cytokine release at all, and there have been patients with limited response despite severe cases of cytokine release. Clinicians are still learning how to predict response and manage toxicities. What we do know is that cytokine release syndrome is a very likely, serious, and potentially fatal reaction after CAR-T therapy, and nurses are at the forefront of patient education and toxicity assessment and management, and we must be aware of how the mechanism of action of CAR-T therapy plays into expected toxicities and management.